will discuss some important questions from anatomy. One of the question was about esophageal constrictions, and it was given as a case history where a 30 years old man, it came with choking episodes after ingestion of fish bone while eating. The fish bone got impacted at the level of T4 in the esophagus, and it was asked like what is the most likely site of obstruction or the esophageal constriction. Now here the topic is actually esophageal constrictions, and there are 4 areas where the esophagus is constricted because of nearby anatomy. One of the important constriction is at the point where the esophagus begins, and this is because of the cricopharyngeus muscle. The second is where the arch of aorta is crossing. The third one is because of the left main bronchus, and the fourth one is because of the entry of esophagus through the diaphragm. So these are the 4 areas where the esophagus is constricted or it narrows down. So if we just write all these, the first one is because of the cricopharyngeus muscle, and it lies at the level of cervical 6 vertebra. The second one is because of the arch of aorta, and it is at the level of T4 vertebra, right? So this is because of arch of aorta, and it is at the level of T4 vertebra. The third one is because of the left main bronchus, and it is at the level of T5, T6 vertebra. And lastly, as the esophagus passes through the diaphragm, it is again constricted. So esophageal hiatus of diaphragm, and this is at the level of T10 vertebra, right? So these are the 4 constrictions: cervical vertebra 6, thoracic 4, thoracic 5, 6, and thoracic 10. So these are the different vertebral levels where the esophagus is constricted, and most commonly, or the most important one in clinical practice, is the cricopharyngeal junction, which is actually the starting point of esophagus. So this is the starting of esophagus. Clear? So one should know the reasons why there is esophageal constriction. Secondly, one should know the vertebral level, and thirdly, and more importantly, one should know the distance from the central incisor. So this is also equally important. So at what distance from the central incisor teeth? So the cricopharyngeal is at the distance of 15 centimeter. The aortic arch constriction is at the distance of 25 centimeter. The left main bronchus constriction is at the distance of 28 centimeter from the central incisors. And lastly, the diaphragmatic hiatus is at the level of 40 centimeter from the central incisor. So you should remember 4 things. Number 1, what is the reason? Number 2, what is the vertebral level? And number 3, the distance from the central incisor. So 15 centimeter, 25 centimeter, 28 centimeter, and 40 centimeter, and this is measured from central incisor teeth. Okay, so please remember this much, and most of the time the question is either integrated as a complication of some procedure like endoscopy, or obstruction somewhere, and then there is the patient having choking episode as given in this particular question. So remember these three things and this topic is done. Then moving forward to the next question, where a man, he fell down on his shoulder and the head was pushed into the towards the opposite direction, and after that he had a deformity where the upper limb was adducted and internally rotated, the elbow was extended, and the forearm was pronated. Now, which nerve roots are most likely affected here? Now, if we go with the mode of injury, which says that the head is pushed to the other side, now what happens here? Suppose if the shoulder is here and the head is here. So what is happening? The head is going to one side and the shoulder is going to the other side. So there is tractional injury at the neck region. So here there is tractional injury at the neck. Now, if we take the anatomy of the brachial plexus, in the neck there lies the roots and the trunks of brachial plexus. Clear? So there lies the roots and the trunks of brachial plexus. So it means there is tractional injury. So this can result in tractional injury at neck, and this will result in tractional injury to the roots and trunk. Now what we see in the image, the upper limb is adducted, means it is touching the trunk. So the upper limb is adducted, it means there is paralysis of abductors. That's why the adductors are more powerful now and they have adducted the upper limb. Then what we can see, the upper limb is internally rotated like this. So it means there is paralysis of external rotators. That's why the internal rotators are more powerful and they are pulling the upper limb in the direction of their action. Then thirdly, the elbow is extended straight like this. So what does this mean? It means there is paralysis of elbow flexors. That's why it is extended. And lastly, the forearm is supinated. It means there is paralysis of forearm supinator. So the forearm is pronated. It means there is paralysis of forearm supinators. So the muscle group which is paralyzed, the opposite side becomes more active and it pulls the limb in the direction of their action. That's the key here. So this is a classical case of Erb's palsy. So this is a classical case of Erb's palsy, and this is because of injury to the upper trunk. And upper trunk, it is formed because of union of C5 and C6. So this is the classical description of Erb's palsy, and this is because of injury to the nerve roots C5 and C6, which joins to form the upper trunk. Clear? So this is a classical picture of Erb's palsy, and in this particular image, this is actually a obstetrical complication, means at the time of delivery, if there is tractional injury to the neck, the baby can have Erb's palsy. So very important topic from exam point of view. Then third question, from extraocular muscles where a patient is coming with a down and out right eye, and it is associated with ptosis. Now, which nerve is paralyzed? Now, you have two ways in which you can solve these questions. Either you go with the theoretical concept of this particular clue, or you go with the theoretical concept of this particular clue. Now, the easier one is if you go with the concept of ptosis. Now, ptosis means drooping of upper eyelid, right? So this means drooping of upper eyelid, and this is possible when there is paralysis of the muscles which are needed for elevation of upper eyelid, right? So paralysis of muscles which are actually elevators of upper eyelid. Now, one should know the two important muscles which are elevators of upper eyelid. One is levator palpebrae superioris, and second is Muller's muscle. Okay, so levator palpebrae superioris and Muller's muscle. The nerve supply of levator palpebrae superioris is oculomotor nerve, and Muller's muscle is supplied by sympathetic plexus. Clear? So this is sympathetic plexus. So it means either of the two is paralyzed. Obviously, this one is much more bigger as compared to the Muller's muscle. So this is classically indicating towards the possibility of third oculomotor nerve palsy. This is one way. Now, if we see here, the down and out right eye. So down and out. Now, down means depression. The eye is going downward. Out means lateral rotation or lateral movement. Clear? So, lateral movement or abduction. Clear? This is also known as abduction. So, the eye is going down and out. It means the muscles which are bringing out these actions, they are more active because the muscles which are bringing the opposite actions are paralyzed. So, it means these are normal. That's why they are pulling the eyeball in their direction. Lateral movement or abduction, this is done by the muscle which is known as lateral rectus. And lateral rectus is supplied by cranial nerve 6th. So it means cranial nerve 6 is normal. So we can exclude 6 from here. So that cannot be the answer because it is normal. Now, down and out. This is also action of another muscle, and that is known as superior oblique. And superior oblique is supplied by cranial nerve 4th, that is trochlear. So it means it is also normal. Facial nerve has nothing to do with extraocular movements. It supplies only muscles of facial movement. So we can say that the answer is third cranial nerve, right? So this is how we can reach up to the answer. Either going with the concept of ptosis, which leads to third cranial nerve, and down and out means abducens is okay, trochlear is okay. So what is left? Third nerve. So here we can say that this is down and out means the superior oblique and lateral rectus are normal. They are not paralyzed. Superior oblique is supplied by trochlear nerve, that is cranial nerve 4, and lateral rectus is supplied by abducens, that is cranial nerve 6. So these are also normal. Ptosis, we can say that it is because of paralysis of levator palpebrae superioris, which is supplied by cranial nerve third. So it means the cranial nerve third is paralyzed. That comes the answer here. So we can see this is the action of lateral rectus, which is taking the eyeball outside or abducted. This is supplied by abducens, and this is the action of superior oblique, taking the eyeball outside and downward. So this is the action of superior oblique. So superior oblique is supplied by cranial nerve 4, and the mnemonic is SO4 LR6 rest by third. So superior oblique by fourth nerve, lateral rectus by sixth cranial nerve, and all remaining muscles by third cranial nerve. So this is how you can reach up to the answer, and very important from exam point of view. Then next question was about infection in cavernous sinus, and there is involvement of a cranial nerve. Now if you want to check the involvement of abducent nerve, which muscle action you will check. So this we just discussed that if we take the nerve supply of extraocular muscles, the mnemonic is SO4, that is superior oblique by fourth, lateral rectus by sixth, and all the remaining by third. So obviously we will look for the activity of lateral rectus muscle, and lateral muscle is actually taking the eyeball outside, that is it is an abductor. Okay, so it is an abductor. So what we will do, we will check for the lateral movement of the eyeball, and this is the cavernous sinus on either side. This is the sphenoid sinus, the sphenoid bone, and you can see this is the sella turcica, in which there is the pituitary gland. Clear? And this all is the cavernous sinus, and in cavernous sinus all the three nerves which supplies the extraocular muscles are present. So cranial nerve third, that is oculomotor, cranial nerve fourth, that is trochlear, and cranial nerve sixth, that is abducens. So third, fourth, sixth, all the three cranial nerves which supplies the extraocular muscles are supplying the extraocular muscles are present here related to cavernous sinus. So whenever there is thrombosis in the cavernous sinus, the manifestations are very widespread. So superior oblique, it takes the eyeball outward, that is abduction, and it takes the eyeball downward, that is depression. And lateral rectus, it takes the eyeball outward, that is abduction. Right? So please remember this much. The next question, a patient has trauma to the lateral side of the knee joint, and then after this, whenever he was walking, he complained that the toes is dragging on the ground, and this is also associated with numbness over the upper lateral aspect of leg and the dorsum of the foot. Now which nerve is gone? Now here important clue is that injury to the lateral part of leg. Then secondly, the toe is dragging. It means the patient is not able to dorsiflex the foot. So this movement is absent, as we can see here. So toe dragging means dorsiflexion is absent. Now dorsiflexion is absent, it means the dorsiflexors are paralyzed. Dorsiflexors, they are supplied by the deep peroneal nerve, and deep peroneal nerve, it cannot be injured as such, although its parent nerve, that is the common peroneal nerve, it can be injured in clinical practice. So common peroneal nerve is injured, and this is especially related to the neck of fibula. So whenever we see a case of fractured neck of fibula, there is possibility that the common peroneal nerve might get damaged, and because of the involvement of the deep peroneal nerve, the dorsiflexors are paralyzed and patient will have loss of foot dorsiflexion, and this condition is known as foot drop. Clear? So this is the point here. Injury to the lateral part of the leg means there is fracture of neck of fibula. Clear? So this is how we have to associate this question. The other branch is obviously the superficial peroneal nerve, but it supplies the everters of foot. Okay, so this is how you have to solve this question. And in clinical practice, the parent nerve is commonly paralyzed rather than the isolated paralysis of deep peroneal nerve. And this is how the patient will present, cannot do the dorsiflexion movement. The next question, a patient has weakness of the right side of the face. There is drooping of the angle of the right side. He is not able to raise the eyebrows on the right side, and also he is not able to close the eyes on the right side. Now, what is the diagnosis? Now, here we can see the classical case. If we tell the patient to close the eyes, this side the eyes are closed, but here they are still open, right? Then secondly, we can see furrows in the forehead on the normal side, but there is no movement here. Clear? So this is one thing. Then third, the angle of mouth is low on the affected side. So this is classical involvement. So here we can see that there is involvement of the forehead, right? So this is the forehead. Then obviously eyes, and lower down the angle of mouth. So the angle of the mouth is pulled towards normal side. Okay, so it means on the affected side it will be at a lower level. So this is the classical infranuclear palsy of facial nerve, right? So infranuclear palsy, facial nerve, and this is clinically known as the Bell's palsy. So this is what is the description of the Bell's palsy. So in Bell's palsy, there is involvement of forehead. So yes, but in supranuclear, it will not be seen. In supranuclear, that is upper motor neuron, the eye can be closed, but in a case of Bell's palsy, it will remain open, as you can see in the image here. Then infranuclear, the manifestations are on the same side of the nerve injury. So suppose if the patient is having right-sided facial nerve palsy, then the patient will have features on the right side only. So that is known as ipsilateral. So that is known as ipsilateral. But in case of upper motor neuron, the changes are seen on the other side, so contralateral. So contralateral means you can say opposite side. And clinically, the lower motor kind of facial nerve palsy is known as the Bell's palsy, and the upper motor can be seen in stroke, that is cerebrovascular accidents. Right? So CVA. So complete involvement of the one half. So suppose if we divide it like this, so one half completely paralyzed, this is lower motor, same side, right? And if there is only lower half involvement, forehead is spared, this is upper motor, but on the other side, right? So that's very important. In upper motor neuron, just remember two things: the forehead is spared and the involvement is on the other side. So that's upper motor. But full face involvement on the same side, that is infranuclear or lower motor neuron paralysis. The next question, a patient has extraction of the mandibular third molar, and after that he had loss of sensations from the anterior two-third of the tongue and floor of mouth. Now which nerve is paralyzed. Now, sensations from the anterior two-thirds of the tongue, they are carried by lingual nerve. Okay? And these are actually the general sensations. And when we say general sensations, what we mean? Cold, hot, right? So these are the general sensations which are carried by the lingual nerve. So if there is loss of sensations, general sensation from the anterior two-thirds, it means the lingual nerve is paralyzed. Okay? So we can say this is anterior two-thirds of the tongue, right? This is the anterior two-thirds of the tongue, and this is the posterior one-third of the tongue. So from the anterior two-thirds of the tongue, if we say anterior two-thirds, and if we divide like this, posterior one-third, and we can write the sensations like general sensations and taste sensations. So from the anterior two-thirds, general sensations are carried by the lingual nerve, and the taste sensations are carried by the chorda tympani. So see, from the anterior two-thirds, the functions are carried out by different nerves, but from the posterior one-third, it is just one nerve which is doing both the functions, and that is glossopharyngeal. Okay, so please remember this. So if there is extraction of mandibular third molar tooth, chances of injury to lingual nerve. And that will manifest as loss of general sensations from the anterior two-thirds of the tongue. So this is how you have to solve this kind of questions, very commonly asked in exam. Clear? So anterior two-thirds and posterior one-third of tongue. So here this is anterior two-thirds, and this is the posterior one-third. Then Frey syndrome, very beautiful concept involving the injury to the auriculotemporal nerve. Now, normally what happens in the auriculotemporal nerve, we have two fibers, the parasympathetic, which is going to the parotid, and the sympathetic, which is going to the sweat glands, right? So sympathetic going to the sweat glands, and parasympathetic going to the parotid gland. So whenever we are eating something, the parasympathetic component will be stimulated, and it will send the command to the parotid gland, and parotid gland will release saliva. Okay, and when the sympathetic system is stimulated, the command will go to sweat glands, and sweat gland will produce sweating. Okay, so this is the normal mechanism. Both the commands are going in separate directions. But what happens, suppose if we are doing any surgery over the parotid in which the auriculotemporal nerve is cut, and once the nerve cuts, there is aberrant regeneration, so that the parasympathetic fibers, they by mistake go to the sweat glands, right? So the parasympathetic by mistake, they regenerate and they go to the sweat glands. So the moment the patient is eating something, parasympathetic, their function is to stimulate secretion. So rather than going to the parotid, now they are going to the sweat glands, and they will promote sweating. So what is happening? The moment the patient is eating something, or the patient is chewing something, rather than salivary secretion, there is sweating. So this syndrome is known as gustatory sweating, because this is known as gustation. So this is the concept of Frey syndrome, very important from exam point of view. And this happens because there is injury to the auriculotemporal nerve, and there is aberrant regeneration of the parasympathetic fibers, which by mistake goes to the sweat glands. Okay, so very important concept. Then a patient had road traffic accident and suffered extradural hemorrhage, and there was injury to some artery. Now, what could be the impact of collision? Now, this is extradural, which is also known as epidural. So, extradural or epidural hemorrhage. Now, epidural or epi word or extra word, it means outside or above. So it means the bleeding is occurring above the dura mater, and this is usually arterial in nature, and the artery which is ruptured here is the middle meningeal artery. Okay, so this is the middle meningeal artery, and this artery is related to one landmark, and that is known as pterion. So pterion is a point of junction where the four bones they meet, and this is the pterion, which is the area adjacent to which on the inner side lies the middle meningeal artery. So if there is any injury to the pterion, there is high chances of injury to the middle meningeal artery, and the condition is known as extradural or epidural hemorrhage. So you should know the name of the artery, and that is the middle meningeal artery. Okay, so this is the middle meningeal artery. And there is one more important point which is frequently asked, like it passes through which foramen? So please remember the name of the foramen, and that is foramen spinosum. So it passes through foramen spinosum. Okay, very small foramen but very valuable because it is giving way to middle meningeal artery. Now this is a CT scan picture where we can see this is the bleeding biconvex. Okay, so this is also very commonly asked in the exam, that what is the appearance of epidural or extradural hemorrhage. So what you will write here, you will say it looks on CT scan, it looks biconvex. Clear? So it looks biconvex or lemon shaped. So this is also one very valuable point and a very important topic. Most of the time we have a question from this particular topic. Okay, then a 45 years old woman presents with loss of sensations around the base of thumb, and specifically it's mentioned first web space over the dorsal aspect of the hand. Now which nerve is injured? It means there is loss of sensations in this area. Now the moment you find this word first web space, dorsal aspect, think of radial nerve. So this is the area where we check the sensations provided by the radial nerve. So if the patient is able to perceive the sensations, we can say that the radial nerve is okay. Now let us see here. This all is the territory of the radial nerve, right? And this is the first web space, and obviously all you can see, this is the dorsum, right? So this is the dorsum of hand, dorsum, or you can say posterior, or you can say back of hand. So in the back of the hand, first web space is the area which is clinically tested to see for the nerve supply provided by the radial nerve. Now here two more questions are very important. Now come to the middle finger. See, this is the middle finger. Now if I ask you, tell me the nerve supply of middle finger on dorsal aspect. Now what we can see here, this is the territory of median nerve. So this all area is supplied by median nerve. Then lateral half is supplied by radial nerve, and the medial half is supplied by ulnar nerve. So middle finger is one finger, the back side of this is having nerve supply from all the three nerves. Clear? So middle finger, dorsum, all three nerves. That's very important. All three nerves. That is radial, median, and ulnar. Okay. So this is also one very favorite question of the exam setters. And then if we come to the ring finger, this all is ulnar nerve, the medial part, and the lateral part is all median nerve. Okay. So this is, but middle finger is very important. Now coming to the volar aspect or the palmar aspect or the front of hand. Now here you have to remember only two nerves. Clear? Just territory of two nerve. This one is median and this one is ulnar. Clear? So what is the point of demarcation? This is the point of demarcation, something like this. So this is all median and this is all territory of ulnar. So we count from here. This is thumb. So first, second, third, half. So lateral 3.5 is all territory of median nerve, and 1 and then half. So medial 1.5 is all territory of ulnar nerve. So please remember this. For radial nerve, dorsum of hand. Median nerve, volar aspect of hand. Ulnar nerve, mainly on volar aspect of hand. Now these are the areas where we actually check the sensations. So radial nerve, we check in first web space. Clear? So we check in first web space. If we want to check the median nerve, we will check in the thenar area. Now, where is the thenar area? This is the thenar area. And if I have to check the ulnar nerve, where I will check? I will check in hypothenar area. And where is hypothenar area? This is the hypothenar area, right? So hypothenar area tested to check nerve supply provided by ulnar nerve. Thenar area tested to check the nerve supply provided by the median nerve. And the first web space dorsum, that is for checking radial nerve. So please remember this cutaneous distribution of the hand, very important from exam point of view. The next question, a patient has loss of corneal reflex but normal facial movements. Which nerve is affected? Now for this corneal reflex, we should know what actually is corneal reflex. So corneal reflex is actually a protective reflex. Now what happens when we touch the cornea with a wisp of cotton? What happens? There is protective blinking of eye. So what is happening? The moment you touch the cornea with a wisp of cotton, it led to blinking. So this reflex, again, it is having a afferent which is taking the command to the center, and there is an efferent which is performing the function. So afferent is sensory and efferent is motor. Obviously sensory, from the face we know that it is trigeminal nerve, especially the ophthalmic division. And motor, this is facial nerve which supplies the muscles of the facial expression, orbicularis oculi, and other muscles, right? So now here what is being written, that facial movements are okay. So the muscles, facial movements, or you can say facial expression muscles, they all are supplied by seventh nerve, that is facial nerve. So the question itself is telling that the facial nerve is okay. So obviously, if the efferent is okay, it means the afferent is gone. So what is the answer here? The ophthalmic division of trigeminal nerve. So that is how we can reach up to the answer. Okay. So since the efferent is okay, and that is actually given as like facial expressions are there, but the reflex is gone, it means the afferent is defective. That's why the reflex is absent. So this is the corneal reflex. Then deep inguinal ring. Now this is very important from surgery point of view. So if we look here in the anatomy of the inguinal canal, there is one deep inguinal ring, there is one superficial inguinal ring, and between the two rings lies the inguinal canal. Now remember, both the openings, like suppose if this is the deep inguinal ring, this is the superficial inguinal ring, and this is the inguinal canal. Yes, so this is the inguinal canal. This is the deep inguinal ring, and this is the superficial inguinal ring. Now both of these, they do not lie in the muscles proper. Deep inguinal ring is in the fascia transversalis, and superficial inguinal ring is in the external oblique aponeurosis. Yes, so external oblique aponeurosis. Fine. So just remember these structures in which this is the deep inguinal ring, this is the superficial inguinal ring, and especially in males, you can see this is how the spermatic cord comes out like this. Okay, so this is the inguinal canal. So the spermatic cord comes out like this. Then identify the epiphysis which is marked with the number 5 here. Now here what we can see, the number 5 is actually the lower end of tibia, and it is participating in the formation of ankle joint. An ankle joint participates in weight transmission. Clear? So what is happening? The body weight is passing like this. So those type of epiphyses which are participating in some joint and weight transmission, or it means they are under continuous pressure of body weight, are known as pressure epiphyses, right? So they're under continuous pressure of the body weight. So the moment you see any epiphysis which is forming a joint and is involved in weight transmission, the answer has to be pressure epiphysis. So the 4 types of epiphysis, the one which we already discussed, it is pressure epiphysis. The second one is traction epiphysis. The third one is aberrant epiphysis, and the fourth one is atavistic epiphysis. Yes, these are the 4 types of epiphysis, and pressure forming joint, weight transmission, and classically you can think of the hip joint, right? Then traction, the muscles are attached and they are exerting a pull or attraction like greater trochanter. Then aberrant, not always present. And atavistic is, originally it was an independent bone, but later on it joins to some nearby structure or nearby bone like coracoid process, which becomes a part of scapula. So these are the four types of epiphysis: pressure epiphysis, traction epiphysis, aberrant epiphysis, and atavistic epiphysis. Okay, so just remember. And if you see any epiphysis which is participating in the joint formation, weight transmission, the answer has to be pressure epiphysis. Then Hasselbalch's triangle, very important from surgery point of view. So if you see here, there is a triangular area, and this is known as the Hasselbalch's triangle. Now let us discuss the boundaries of Hasselbalch triangle. It has got one medial boundary, one lateral boundary, and one inferior boundary. Now medially, this is the medial boundary. Of course, we are looking at the right-sided Hasselbalch triangle. We see one muscle here, and this muscle is the rectus abdominis. So the lateral border of rectus abdominis. Then laterally, we can see vessels, and these vessels are the inferior epigastric vessels. So inferior epigastric vessels. Okay, so these are the inferior epigastric vessels. And lower down we can see one ligament, and this ligament is the inguinal ligament. So lower down we can see the inguinal ligament. So these are the boundaries of Hasselbalch's triangle. Now, what is the importance of Hasselbalch's triangle? And this, for this you need to understand what is hernia. Now, hernia means part of GIT is coming out of the superficial inguinal ring. Clear? So it is coming out of superficial inguinal ring. Now there are two ways in which it can come out of superficial inguinal ring. One is either it can enter into the deep inguinal ring, travel through the inguinal canal, and then it can come out through the superficial inguinal ring, or it can directly enter into the inguinal canal through the posterior wall, and then it can come out through the superficial inguinal ring. So there are two mechanisms. One is indirect inguinal hernia, and the another one is the direct inguinal hernia. Indirect is the one where the content enters through the deep inguinal ring, right? So this one is direct, entering through the deep inguinal ring, traveling through the inguinal canal, coming out through the superficial inguinal ring. This is indirect, especially seen in children's. And if the content enters through the Hasselbalch's triangle into the posterior wall and then come out through the superficial inguinal ring, this is direct. Clear? This is direct. So that's why Hasselbalch triangle is very important for direct inguinal hernia, and this is especially seen in adults. So these are the two important points based on which we have questions at times. So please remember Hasselbalch's triangles, which is related to direct inguinal hernia, and direct inguinal hernia is commonly seen in adults. The next question, a patient has difficulty in extending the wrist and he had a fracture of the shaft of humerus and there was loss of sensations over the dorsum first web space. Now the moment you find this word, loss of sensations on the dorsal hand first web space, this we have just now discussed, because this area is having nerve supply provided by the radial nerve. Now, if you know this clue, you can reach up to the answer, but we will consider this clue as well. Now, what is happening? The radial nerve passes behind the humerus from medial to the lateral side, okay? through the spiral groove, which is also known as the radial groove, because through that groove, the radial nerve is passing. So that groove is also known as radial groove. So a spiral groove is also known as radial groove because the radial nerve is passing through that, and it lies on the posterior aspect of humerus. Now, whenever there is fracture of mid shaft of humerus, the radial nerve can get entrapped and radial nerve can get injured. So if there is any fracture involving this particular area, it can cause injury to the radial nerve. So radial nerve paralysis can occur, and the extensors of the wrist are paralyzed. So radial nerve paralyzed means extensors of wrist paralyzed. Now, extensors of wrist are also known as dorsiflexors. These are also known as dorsiflexors. And therefore, the clinical deformity which will come out here is known as the wrist drop. Clear? So, this is how the patient will have wrist drop. So, one of the classical deformity with radial nerve injury is wrist drop, where the patient is not able to dorsiflex the wrist, or he will not be able to extend the wrist. So that is wrist drop. Ulnar nerve palsy can lead to ulnar claw hand or partial claw hand. Median nerve can lead to pointing index finger. These are some commonly asked questions in the exam, so I have kept a box for that. Posterior interosseous nerve, it will result in finger drop. Now please look here, this is wrist drop, this is finger drop. In wrist drop, there is no extension at the wrist. In finger drop, there is no extension at the metacarpophalangeal joint, right? So no extension at metacarpophalangeal joint. Axillary nerve leads to paralysis of deltoid. So there is atrophy of deltoid. So what we see? Flattening of shoulder, because the rounded contour of shoulder is because of deltoid. So if the deltoid is gone, flattening of shoulder. Musculocutaneous nerve, it will result in loss of sensations in upper lateral forearm. Clear? And along with the paralysis of the three muscles of the anterior compartment, namely brachialis, biceps brachii, and coracobrachialis. So these three muscles will be paralyzed, although brachialis is half paralyzed because it is also getting nerve supply from radial nerve. Clear? So this is in short which you should remember about the nerves of the upper limb. Then moving forward to another question where a patient has a stab wound to the axilla and now he cannot abduct the arm beyond 90 degree. It means 0 to 15 degree is possible, and more than 15 degree abduction is not possible. And here you need to know the anatomical concept of the different muscles which are used during different degrees of shoulder abduction. So one is 0 to 15 degree, second is 15 degree to 90 degree, third is 90 to 120 degree, and last is beyond 120 degree. Now the muscle which is responsible for abduction for 0 to 15 is supraspinatus. The muscle which takes the upper limb from 15 degree to 90 degrees, deltoid. The muscle which takes upper limb 90 to 120 degree of abduction are two actually. trapezius and serratus anterior, and lastly beyond 120 degree there is no muscle, it is only scapular rotation. Okay, so there is no muscle involved here. Now look at the question. The patient can do 0 to 15 degree, but he cannot do 50 to 90 degree. It means supraspinatus is working, but deltoid is not working. A muscle will get paralyzed if the nerve supply is paralyzed, right? Supraspinatus, it is supplied by suprascapular nerve. So it means suprascapular nerve is okay. So this cannot be answered here. Deltoid is supplied by axillary nerve. Clear? So therefore, the answer will be axillary nerve. So this is how you have to apply the anatomical concepts to reach up to the answer. The next question, a patient cannot rotate his head to the opposite side, and also there is shoulder drooping. Which nerve is involved? Now here, two important clues are given. Cannot rotate head to opposite side. It means some muscle is paralyzed. And as I said, a muscle will be paralyzed only if the nerve which is supplying that muscle get paralyzed. So firstly, you should know which muscle is responsible for this particular action. So rotation of head to the opposite side, this is possible because of sternocleidomastoid. Then shoulder dropping means the activity or the action which is absent is shrugging. So no shrugging of shoulder. And shrugging of shoulder is done by trapezius. So it means trapezius is also paralyzed. And both the muscles, they have the common nerve supply, and that is spinal accessory nerve. Clear? So the answer here will be spinal accessory nerve. If there is injury to the spinal accessory nerve, the sternocleidomastoid muscle is gone, so the patient cannot rotate the head to the opposite side, and the trapezius is gone, so the patient cannot shrug the shoulder, so the shoulder will appear dropped. So this is dropped shoulder, you can say. Yeah, so the answer is spinal accessory. The next question, a patient has difficulty in climbing stairs and rising from sitting position. Now this clue is very important, rising from sitting position. Now what happens here, whenever we are doing these activities, the movement which is taking place at hip is actually extension. So there is extension at the hip. Now the patient is having difficulty in doing these movements. It means there is difficulty in extension. So it means the muscle which is bringing out extension at the hip is paralyzed, and that muscle is gluteus maximus. So it means the gluteus maximus is paralyzed, and gluteus maximus is paralyzed if the nerve supply to this muscle is paralyzed, and it is supplied by inferior gluteal nerve. Okay, so this is how you can reach up to the fact that there is paralysis of inferior gluteal nerve. Because of this nerve, gluteus maximus is paralyzed, and if gluteus maximus is paralyzed, it means there will be no extension at the hip, and therefore patient will find difficulty in doing those movements at the hip joint which involves extensions, namely climbing stairs, or more importantly, difficulty in rising from sitting position. So this is how you can reach up to the answer. The next question, a lady is walking with a lurching gait and the pelvis is tilting on the unsupported side while walking. Now which nerve is injured? Now here the concept of Trendelenburg test or Trendelenburg sign is discussed. So Trendelenburg sign or Trendelenburg test. Now what happens? Normally, when we are standing on both the limbs, the pelvis is in a horizontal manner and both the anterior superior iliac spines are at the same level. Okay, so what we check actually? Anterior superior iliac spines. So anterior superior iliac spine, anterior superior iliac spine. So both the ASIS are at the same level. Now suppose if we tell the subject to lift one limb like this, now what will happen? There is a tendency for this unsupported side to go downward because of the effect of gravity, because now he is not taking any support from the ground. So this side pelvis can go like this. But what actually happens? The abductor mechanism on the side to which the person is standing, this is supported side and this is unsupported side. It means the foot is taken off the ground, unsupported. So what is happening? The abductor mechanism of the side to which the person is bearing weight or is standing, it contracts and it lifts the pelvis of the other side so that both the ASIS, they lie at the same level. So this is the Trendelenburg test or sign which is actually checking the abductor mechanism. If the abductor mechanism is okay, both the anterior superior iliac spine should be at the same level, even though the patient has lifted 1 foot off the ground, right? So this is normal. So here if we see, this is the supported side, okay? This is supported and this is unsupported, taken off the ground. Now, the normal tendency was that it should go down like this under effect of gravity. But the other side abductor muscles, they tilt the pelvis downward on the supported side so that on the unsupported side, it goes upward and therefore the anterior superior iliac spine of both the sides, they lie in the same plane. But suppose if this is paralyzed, if this abductor mechanism is not present, obviously the pelvis will drop down. So what we'll see on the unsupported side, the ASIS will be at a lower level as compared to the ASIS of the normal side over which the patient of the other side over which the patient is bearing the weight. So we have to just look at the ASIS of both the sides and the abductor mechanism is checked on the supported side. Okay, this is very important. And waddling or lurching gait, this is again based on the abductor mechanism. So what we are looking actually, abductor mechanism at hip. Now abductor mechanism at hip involves three things. Obviously, one is muscle power, then second is neck of femur intactness, and third is the hip joint integrity. So if these three are okay, then only we'll get a normal abductor mechanism. If any of the three is absent, the Trendelenburg test will be positive. So here the question is about muscles. So the muscles which are checked here are the gluteus medius and minimus, and these are supplied by the superior gluteal nerve. So which nerve we are checking actually here? Superior gluteal nerve, because superior gluteal nerve supplies gluteus medius and gluteus minimus, which are the abductors of the hip joint. Here, so this is a very beautiful concept of Trendelenburg test, which checks the abductor mechanism at hip, which involves muscle, neck of femur, hip joint. The next question, A patient presents with deviation of the tongue to the right side on protrusion. Now here, if there is wasting also, wasting means atrophy, or you can use the word flaccidity. So this all suggests lower motor neuron paralysis. Lower motor neuron paralysis, and especially it is for cranial nerve 12, that is hypoglossal. So in case of lower motor neuron paralysis of 12th nerve, the tongue will deviate to the same side of the injury. So if it is going on the right side, right, it is going on the right side, we can say that it is right hypoglossal. Clear? So lower motor, the tongue will deviate to same side. So just remember this, same side deviation. So for hypoglossal nerve palsy, we have two ways, either upper motor neuron or lower motor neuron. Now in upper motor neuron, the tongue deviates to the opposite side, whereas in lower motor neuron, it deviates to the same side. In lower motor neuron, it will be flaccid or atrophied, but in upper motor neuron, it will be spastic. So this is how we differentiate the 12th nerve palsy, whether it is upper motor neuron type or lower motor neuron type, right? So in case of lower motor neuron, if the tongue is going on to the right side, you will say that it is paralysis of right side 12th nerve. If it is upper motor neuron type of palsy, if it goes to the right side, you will say it is left-sided cortical lesion, left-sided upper motor neuron lesion. Okay, so this is actually the concept of upper motor neuron and lower motor neuron. So lower motor neuron is involvement of the nerve itself, and we can see the wasting or the atrophy of the tongue here. So it is going on to the one side, it means this side hypoglossal nerve is paralyzed. So this is how we check clinically. Then next question, a patient presents with inability to adduct the thigh after pelvic surgery. Now, adduction is not possible. So we should know which nerve supplies the adductors of hip, and this is actually obturator nerve. So it means during surgery, which nerve is injured? Obturator nerve is injured, and therefore the patient is not able to adduct the thigh or adduction at the hip. Now abductors we just discussed, the gluteus medius and minimus, which are supplied by the superior gluteal nerve. Okay, so please remember these two important groups. Adductors, especially involving adductor longus, adductor magnus, adductor brevis, pectinis gracilis. Okay, and the abductors, which is the gluteus medius and gluteus minimus, supplied by superior gluteal nerve. The next question, a patient has weak flexor pollicis longus and weak flexor digitorum profundus of index finger. Now this is very important, you should know the nerve supply. If the flexor pollicis longus is weak, it means there is paralysis of the nerve which is supplying it. It means that is anterior interosseous nerve. And classically, weak flexor digitorum profundus of index finger, this is also supplied by anterior interosseous nerve. Now this nerve is actually division of median nerve. Okay, so this is a division of median nerve. So here we can go with the answer median nerve. Now remember, note down one thing, flexor digitorum profundus of index finger. Now why it has been written like this? Because flexor digitorum profundus is a hybrid muscle. Clear? It is an hybrid muscle, And when we say hybrid muscle, it means it has two nerve supplies. So it has got two halves. One is lateral half, another is medial half, something like this. Okay, so this is lateral, this is medial. The lateral half is supplied by the anterior interosseous nerve, and the medial half is supplied by the ulnar nerve. Clear? And the lateral half is going to the index finger and the middle finger, and the medial half is going to the ring finger and the little finger. And therefore, if the examiner is asking you about index finger FDP, it means he is asking you something about the median nerve, or more specifically a branch of median nerve, that is anterior interosseous nerve, right? So this is very important. So the moment you find any mention of index finger, always think of injury to median nerve. Clear? So very important. Then a patient presents with loss of plantar flexion and absent ankle jerk. Now plantar flexion, it means the patient cannot bring the toes down. Clear? So this movement is not possible, and it means the plantar flexors are gone. So paralyzed plantar flexors. In the previous question, we have discussed about the dorsiflexors. So the plantar flexors are supplied by the tibial nerve. So this is tibial nerve. And in previous question, we discussed about the dorsiflexors, which are supplied by deep peroneal nerve. Okay. So this is the thing which you should remember. So no dorsiflexion means deep peroneal nerve paralyzed. No plantar flexion, it means tibial nerve paralyzed. Then this we have already discussed, loss of taste sensation from the anterior two-third. We already discussed that this is cauda tympani, right? So there is loss of taste sensations from the anterior two-third. So taste sensation from anterior two-third, this is cauda tympani nerve. So if there is no taste sensation, it means the cauda tympani nerve is gone. General sensations, we discussed previously, it is lingual nerve. But from the posterior one-third, both the sensory modalities, taste and general, it is by glossopharyngeal nerve. Okay, as simple as that. Then next question, a lady was having an abscess in the posterior triangle of the neck, and then the surgeon did incision and drainage, but later on the lady found difficulty in doing overhead abduction, like combing her ear. Now what could be the reason for this? Now see, this is the posterior triangle of the neck, right? Anteriorly this is sternocleidomastoid muscle, and posteriorly this is the trapezius muscle. So this is the posterior triangle of the neck, and in posterior triangle of the neck there is one important nerve, that is spinal accessory nerve. So sometimes what happens, whenever we give incision here, there is a possibility that we can cut the spinal accessory nerve. Now, spinal accessory nerve, in one of the previous questions we discussed that it supplies two muscles, namely the sternocleidomastoid and the trapezius. So IND, incision and drainage done in the posterior triangle of the neck, possibility of injury to spinal accessory nerve. And this manifests as difficulty in abduction within this range, so 90 to 120 degree. Okay, so we discussed that it is possible because of this resulted because of injury to the trapezius muscle. Clear? So this is the classical description of this particular case, in which the patient had injury to the trapezius which is one of the muscle needed for abduction of the shoulder beyond 90 degree. And the other muscle which is supplied by the spinal accessory nerve is obviously the sternocleidomastoid. Okay, so this is enough for this session. We will meet shortly with another subject. Thanks for joining. This session